Good afternoon, everyone. I'd like to welcome you to our launch event of the National Green Theatres programme and thank you in advance for your attendance. We will be recording the event and making it available on our website to be viewed by those that aren't able to make it just now. And we anticipate that we'll have between 300 and 400 people attending the event. We're delighted to be joined by Caroline Lamb, Chief Executive of NHS Scotland, and Jason Leach, National Clinical Director of Health and Quality, who will set the scene. We'll then cover the aims and visions of the programme, and we'll have a talk from Alethea Chakera, Head of Pharmaceutical Sustainability from the Scottish Government, to highlight the importance of the work to reduce emissions and resulting from our use of anaesthetic gases. Presentations will be followed by questions and answer section. So if you do have questions that come up during the event, if you can please pop those into the chat, it will be monitored and we'll try and cover as many questions as we can at the end. Before we start, we'd just like to do a quick poll of those people that are here, and it should pop up on the screen shortly. If you could indicate the area from the NHS or Scottish Government that you're attending from and just submit that, that would be absolutely great. Thank you. We'll leave the poll running, but it looks like we've got a really good mix of people from across the NHS and Scottish Government colleagues. I'd now like to hand over to Caroline, who will sort of just introduce and welcome the event. Thank you.
Thanks very much, David. And it is really great to see so many people joining us today. So thank you, and thank you to the Centre for Sustainable Delivery for inviting me along to help to launch the National Green Theatres programme. I'm Caroline Lamb. I'm Chief Executive of NHS Scotland and Director General for Health and Social Care at Scottish Government. Climate change is one of, indeed, possibly the biggest challenge that we will ever face. And as Antonio Guterres said last week, in a nod to the Oscar-winning film, the world needs climate action on all fronts. So it really does have to be everything, everywhere, and all at once. And as Chief Executive of NHS Scotland, I am acutely aware that the climate emergency is, of course, also a public health emergency. We only need to look at the extreme heat waves, droughts, floods, and wildfires that have taken place across the world to see that the danger that climate change poses to our health. Predictions of its future impact are startling. Between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year. And in that context, we can be under no illusion about the level of change that's needed. So like other healthcare systems around the world, NHS Scotland must play its part in tackling the climate change crisis by further cutting our own emissions and becoming environmentally more sustainable. In the run-up to COP26, Scotland became part of an international coalition of over 60 countries who have committed to developing low-carbon health systems. And we've been busy on a range of fronts to lay the foundation for a more environmentally sustainable NHS ever since then. However, whilst governments produce strategies to tackle climate change, we can't implement them on our own. We need the help of everyone involved in the NHS to achieve our net zero ambitions. And sometimes climate change and tackling something that just appears so huge can be quite remote to individuals. But action is really needed at a local level where individuals can be really influential in determining actions and implementation. And local level change is exactly how the pilot project for Green Theatres began in NHS Highland. It's a great example of how action at an individual level can grow in momentum and provide a model that teams across Scotland can follow to help to cut emissions. And that's why it's so fantastic to be here today and to see that local initiative develop into the National Green Theatres programme, which we're launching, and which marks a really important step forward in NHS Scotland's path to net zero. Of course, theatres are high carbon energy intensive areas that produce huge volumes of waste. And whilst the care that's provided in theatres is absolutely critical, we know that reducing the environmental impact of theatres has the potential to make a significant dent in our NHS emissions and to deliver better value care. That earlier success by NHS Highlands through their pilot work shows us that change is possible. I'm confident that the modifications to theatres across your respective boards will prove just as successful. So I hope that you find today's session valuable and that you'll be able to see the opportunities for your work. Thank you once again to the Centre for Sustainable Delivery for getting the programme to this stage. But let's not forget that to achieve our net zero ambition, we need everybody to contribute. So with that in mind, I'm inviting everyone across our services to get involved in considering what more we can do in NHS Scotland to implement sustainable change in how we deliver care. I look forward to seeing the results across theatres in your respective health boards over time. But for now, I'm going to hand over to our National Clinical Director, Jason Leach, to explain why what we do in healthcare matters. Thank you very much. Lovely to see you all.
Thank you, Caroline.
Jason, unusually for you, you're muted.
Oh, I am. Look at that. You missed
something I normally love.
You missed about 3 jokes there. I said, David, will I just go, or are you going to do an overly flattering introduction, or will I just start?
I was going to do an overly flattering introduction, but you've done it for yourself, Jason, so you can just start.
So let's just start. Thank you, Caroline, and thank you, David, and thank you for everybody for having both Caroline and I today. It's not as if there's much on in the government, so we're grateful for the break from what is frankly between now and this afternoon just gossip anyway, but it's quite fun to gossip. If any of you know who the new health secretary is, then type it into the chat, but don't put any jokes in the chat because it might be FOIable and we'll get in trouble. So a new health secretary today or tomorrow. So it is quite an exciting time for those of us in government, a bit destabilizing. This will be my 6th health secretary, which indicates I've been there too long, frankly, is the most important thing it reflects. Caroline has been there a little bit less time than me, but has been in the health service no less time, so she doesn't get away with that. But she today and the next few days are huge, particularly for Caroline and those around her. So keep us in your thoughts. I know for sure that whoever gets the job, this agenda will matter because it matters to the new incoming First Minister. It matters deeply to him. Partly because he sees his kids and his family and others around him, but I know he also took it very seriously on a personal level. And one of the reasons why we're here is his leadership and his predecessors' leadership. I feel as though I'm standing on the shoulders of the people who are going to speak after me. So it's a little bit cheeky for me to do any kind of introduction when there's a set of experts here, both in climate change, but also on the Green Theatres work. But I'm going to steal their thunder anyway, because you all know Ken, probably, and Alethea and others who are going to do the content knowledge and the real work. But let me try and introduce this subject, do a little bit of NHS work, and then think about where we might be headed as a whole system, from government through to those of you in theatres and primary care or whatever else you might be. This challenge is not new. This challenge is centuries old. It is new in the sense of its urgency, probably, but it's not new overall. This is the Popular Mechanics Journal of 1912. It's just astonishing that we've been thinking about this for all this time. One of my improvement heroes, and those of you who know me will know my passion is system change. I've just come from a meeting this morning, and I'm going to go back to it shortly, of about 20 European countries who are here in Scotland to learn about systems improvement. The Healthcare Alliance Europe is in town, and they got a lovely grey Glasgow day for it, but they're learning how Deming and others have led us on this systems redesign journey through patient safety, person-centred care, education, And now into climate change. Some of you might know this. This is the Sphinx, so-called. It is in the Cairngorm Mountains. It is the last piece of snow that lasts most winters in Scotland. There are small patches of snow left in the Cairngorm Mountains that are protected from the heat, and this one lasts the whole summer, except in the last 300 years, it's melted completely 8 times. 8 times in 300 years, 5 of which are in the last 10. So it's just a Scottish local introduction and local example of the big graphs that you see of heat around the world that tell you the world is getting hotter. Well, I can tell you it's getting hotter here too. And the Cairngorm Sphinx is just one tiny example of where that is. This is Ian Cameron, who we have to thank for monitoring these pieces of snow. This is what he does, would you believe? He monitors Scotland's last pieces of snow in the spring and in the summer. This crowd probably doesn't need these data, but you get the idea. You can see without any shadow of a doubt the increase in temperature over the last 10 years. And you all know the 1.5%, the 1.5 degree target, whether we're going to do it, whether we're not COP20, you all know that world. And these are the projections. This is the most important thing about this chart is the gap. And the gap is the red arrow going right down, because that 1.5 degree drop is where we have to be to not see the challenges worsen. We're already in trouble. I was in the Middle East a couple of weekends ago, and they are talking about it. They're of course talking about it as fossil fuel producers, but they're also talking about it for the first time in my hearing about the harm that they're seeing across their institutions. I was in India earlier in the year, and you cannot fail to hear the stories of typhoons and floods and droughts and everything you expect. So it is affecting others faster than us, but it is also affecting us. Which takes us then to the transition to why on earth does healthcare care? Well, there's a number of reasons. That there is the air pollution piece, which is a different meeting. It's an important meeting, but there's a different piece about what the climate harm is doing to human health. So that's one piece. But there's also the contribution and the responsibility health and care have in order to reduce the harm globally. So here we are. We think it's not an exact science, but it's estimated that the national health services across the 4 countries make up about 40% of the UK's public sector emissions. 40% of the UK's public sector emissions. If you just imagine Blackpool, 30% of Blackpool works for health and social care. So the footprint is enormous. Even in the institutions you're almost certainly sitting in or working in, you'll know how big they are compared to everything else in your town or city. 165,000 employees with NHS payslips and tens and tens of thousands more in our social care system, our production, our supply chain. We use more paper cups than anybody else in the country. We cut more grass than anybody else in the country. We heat more buildings than anybody else in the country. We are the biggest everything across the Scottish public sector. This is a Pareto chart of our climate footprint. A Pareto chart tells you where you should start your work, and you won't be surprised to see in here the heating and the energy use, but then you begin to see where else you might be able to make a difference in facilities, in care, in other parts of the system. Hence the reason we're here doing the Green Theatre launch. Now, Scotland loves a strategy, although the outgoing First Minister once threw one at me and said, if you bring me another strategy, I'm not going to tell you exactly what she said. But she liked action, not strategy. And that's why this is an actual plan, a new target date for net zero emissions for all greenhouse gases. And this is the overall plan, and that led to our sector strategy. So this is now pretty globally recognized as a really out there document, a really forward-thinking example of how we might think about how healthcare's contribution and work could help this. You'll notice the cover is Kirkwall. I don't know if there's any Orcadians in the crowd, but it's a beautiful new hospital built by an architect to simulate the standing stones of Orkney. It's an amazing institution, and it's our first net zero hospital build. It has all the primary care in one of the circles, all the secondary care in one of the other circles, and then combined in there a kind of linking corridor and section with theatres, ambulances, boilers, everything you would expect. And it illustrates where NHS Scotland is trying to get to. But it's a lot of work to do. This is our health system. I'm not sure if you knew it looked like this from space. It's all different tartans, every health board. 5.5 million people, billions of pounds, 14 delivery systems, ranging from that Orkney single city, single town, up to the Queen Elizabeth, 1,500 beds, a helipad on the top, the biggest new build hospital in Europe for the last 10 years. And then also trying to integrate that with health and social care. This is a massive undertaking to try and get this to net zero by 2040. So inside that strategy, there are 5 themes. There's, of course, exactly as you would expect. This crowd, if I'd said to you, how would you divide up this challenge? You would probably have done these 5 things. Sustainable goods and services, sustainable travel, sustainable buildings and land, because we own a lot of land across the country and we have massive buildings. Sustainable communities, those you serve and those you're around. But for today, and it's not, I mean, the boundaries are blurred, of course they are. It's not one thing. It's the sustainable care section. So we have, of course, we're the government. So we have governance and we have committees, you would expect. So we have a jointly chaired overall thing, chaired by John Burns, the Chief Operating Officer, and Gregor, the Chief Medical Officer. And then some of us put our hands up, willingly or unwillingly, to run some of the other work streams. So my work stream is sustainable care. So I am chairing, in inverted commas, but again, lots of people doing the actual work around what that sustainable care piece is. Now, sustainable care is going to evolve over time. We get more evidence, we get more news, things change, we get to know more stuff, but we're starting with 3 big subjects, one of which is today. And fortunately, Ken and a host of others were already in this space. And as I learned more, I went round the country, went to Paisley, went to Ninewells, went to Raigmore, and saw some of this work in action. And I'm not going to steal all of the thunder of those around me, but this is one of those theatres where I was fortunate enough to learn what was going on. I think this was probably Raigmore. I couldn't be certain. Might be Paisley, actually, because I'm taking the Europeans there tomorrow. So I hope they're ready for that visit when the 20 European countries suddenly turn up on your doorstep tomorrow to show off this work tomorrow. This is the Green Theatres project, which you're going to hear a lot more about later on. And it's everything. It's everything from your coffee cup to your anaesthetic gas. It's recycling, it's nitrous oxide, it's heating the patient, it's everything you can possibly imagine. In a bundle, for those of us who are quality improvements, in a bundle of care that will together be part of the solution for the big number. Green Theatres is not going to solve the net zero target of 2040. Of course it's not, but it's one element that we're using to get us there. Inside that is, of course, anaesthetic gases. You already know these data and the dangers, particularly of desflurane, and the fact that desflurane, you can use any analogy you like, but cars is often the climate change comparison of choice, and a single bottle of desflurane is 3,000 miles of driving in your car, which would get you to southern Italy if you left London today, although there's a bit of water in the way. And Scotland, as many of you will know, and some of you led, has managed to get desflurane down. It's taken some years, and that's one of the challenges of these pieces of work, is it takes a long time to get there. But just a couple of weeks ago, Scotland became the first to take it off procurement lists. The BBC called it a ban. It's not quite a ban, because there are some very, very niche clinical indications, very niche, not as many as perhaps some of our colleagues think. So you can still get it, but you need to, it's a bit like getting cefuroxime, those of you who were surgeons, when we started doing C. diff, and I had to go and give my firstborn and 3 pints of blood to get cefuroxime from the pharmacist at the Victoria. So you can still get it, but you need to beg. And so it's not going to be on the anaesthetic machines in Scotland's hospitals. We've done this before any other country in the world has done so, and it's testament to the work of hundreds and hundreds of people, some of whom are here. Very quickly, and Alethea and others are here, people who understand this work a lot better than me. The second big subject, not for today, but the second big subject is medications and inhalers. You'll know the data here that the UK uses the dangerous and damaging inhalers much more than the rest of Europe, and certainly a lot more than the Danes and the Norwegians who I've just left in a room. They are down at 10 to 30% of propellant use. And we in the UK are notoriously high. We also, of course, have not great asthma and COPD control. So this is an opportunity to review clinical care, but to review clinical care at the same time as doing something unique for the environment. Again, it's about the same as 100,000 transatlantic flights using the metered dose inhalers. Now, finally, a little bit of encouragement, but before you all get too depressed and it feels too hard. This is ScotGem. Many of you will know ScotGem. ScotGem is our graduate entry medical school, where those with degrees work in general practice. They're often in quite disparate areas. Dumfries, Tiree. There's one of the students on Tiree. Quite a lot in the Highlands. This is Dumfries, and in their final year, they do a 9-month team-based improvement project. And they've done a 6-week one in third year. And then in final year, they do a big, long-term quality improvement project. And it's to teach them the toolkit that I and others try and teach the country around quality improvement. So I've spent a bit of time with ScotGem over the last 2 months, trying to encourage them and thank them for COVID and all the things you would expect, and get out on the road a wee bit rather than at my desk. And pretty much every student in ScotGem has chosen climate change. Pretty much everyone. It's completely generational. And they've done recycling in general practice, they've done inhalers, they've done gases, they've done the whole gamut of climate change. So I am encouraged that the next generation are taking this hugely seriously, but we have to help them. We have to give them permission. We have to sometimes just get out the road and let them do it. But these two are final year students about to be graduates, and will probably be primary care doctors. Probably that is the intention of ScotGem. They're not restricted. But that's our hope, that many of them will stay in primary care and develop this work over time. So that's my brief introduction, David. I hope that sets the scene for what is a hugely important piece of work. It has the Scottish Government's support, it has ministerial support, and it certainly has Caroline and I's support. So thank you all for listening.
Caroline and Jason, thank you so much for sort of setting the scene for us and showing us how the work that we are doing is so important to the sustainable care programme. I'd be really keen and interested, and I think part of the programme is learning from others and other nations as well, especially those Scandinavian nations. And I'd be really interested to learn more of the ScotGem work and see if there's things there that we could pull into the programme. So thank you. I think you can stay for some of the time, but and I think Caroline hopefully can stay to the end, subject to any announcements, I suppose, going forward. I suppose at the start of March, the Cabinet Secretary for Health, as he was then, and now I suppose almost First Minister, issued a letter to chair boards and chief executives that sort of highlighted the triple planetary crisis in climate change, pollution, and biodiversity. And as part of that, he reiterated the fact that climate change is probably the biggest health crisis that's going to face humanity in the future. And indeed, the Intergovernmental Panel report on climate change, which was recently published, has again highlighted how critical we are to not making that 1.5% target. And I suppose it really is imperative that as a health system, we play our part to ensure that the work that we do and the treatment we give doesn't have a detrimental effect on the planet and the health of the population as a whole. I'm going to ask people to do just a little poll here. This one is one where you rank they rank things, and you can move it up and down with the arrows that you've got. And we're just asking people to let us know what they see as the biggest challenge to them affecting any of the positive impacts in climate change, you know, whether it's finance, resources, whether it's knowledge that you've got, senior management buy-in, or a willingness of frontline staff. So if I can ask you all to just sort of move that, we'll leave the poll running, and at the end, we'll maybe pick it up again and just see where people see what the biggest challenge to doing this is. And also it'll help us maybe move the programme to allow us to make some changes as we go forward. Jason, we heard from Jason about the strategies and the importance of it, but for the Green Theatre programme, really, I think that the biggest importance for us was that it said and called out that the Green Theatre programme should be initiated. You know, we estimate that theatres contribute to about 1/3 of the carbon footprint of NHS Scotland and the acute sector. So it's a really good, important bit for us, but it's also a nice contained area that we can look at. But how are we going to do this? Because it's a huge challenge, as has been already highlighted. And, you know, with the imminent threat to climate change, we all need to take action, and we can't just do this by sitting back and waiting for someone else to deliver it. So we have taken sort of a grassroots approach to the programme, and it has been developed to make sure that we can find those areas of positive actions. And obviously the foundation of that has been the Green Theatre project that was run at NHS Highland. We're taking those actions and we're packaging them up into something that can be delivered, but not only delivered, but will have clinical and technical evidence behind it. So we don't want everyone to have to do it, but we want to be able to give you an area to look at. So we are looking at various areas. We've got another chart for this that we wouldn't have been able to read on the screen, but we're targeting multiple areas within the theatre environment. We're looking at and considering the physical estate that we've got and how the buildings are made, the ventilation. We're going to optimise and reduce waste segregation in theatres, looking at what waste is generated and whether we can work with procurement to actually reduce the amount of packaging and things that are coming in. Obviously, we're reducing the impact of volatile gases that we use in our theatres. And as already been highlighted, desflurane is a great example of a grassroots-led change, and Ken will talk more about that a little bit later on. We also need to consider the efficiency of the equipment that we're using. I think if you looked at Jason's slide, you know, energy use is one of our biggest areas of emitting. And we're also going to start looking at treatment pathways of patients as they come through and identify how we can make that pathway more sustainable in an environmental sense. And that sort of combines with other work that the Centre for Sustainable Delivery is doing in patient pathways, where we're looking for sustainable care. With all these areas, we'll work closely with our national organisations because we're a small team in the Green Theatres programme. So we will be working with NHS Assure, for instance, National Education for Scotland. There's many areas within the NHS that are already looking at this problem. So we'll work with the waste managers, infection control, just to make sure that what we're doing isn't duplicating work, but is promoting work that a lot of other people are doing within the areas that we're talking about, such as active transport, where for the theatres, we want to make sure that people are travelling, and that's the staff are travelling there, but we're not going to solve that problem, but we can work to promote that within the theatre environment. We've developed a sort of 4-stage process that we're going to be looking at, and this is making sure that the actions that we're doing are going to be identified. First of all, we'll carry out a rapid assessment of those actions to understand the benefits, carry out a formal, what we're calling an opportunity for change assessment, working with the project managers and the team and the clinicians and the service users. We will sort of write something that's akin to a mini business case maybe other people can understand it as, to actually say what the impacts of the change are. And finally, once we go back through our speciality delivery group, which we'll hear more about later on, we'll launch the action with a how-to guide that will contain the steps to implement this at a health board level. Now, we all need to be involved in the change, and what I think the programme can do is throw the pebbles and send the ripples out, but we really are dependent upon everyone in the NHS health boards to pick up these actions and deliver them at a local level. What we will try and do is give everyone actions that are manageable, evidence-based, and moving forward. So the next part, and he has already had an introduction, is Ken Barker, who's our clinical lead in the programme and has really been one of the driving forces behind the Green Theatre project at NHS Highland, which really is the foundation of our programme, and we wouldn't be here without Ken, so I'll let Ken now take over.
Thank you, David. Good afternoon, everyone, and I'd like to thank everyone very much for attending the launch of the National Green Theatre programme today. We have about 446 colleagues registered to attend across many different areas in NHS Scotland. So it's really encouraging to see so much interest in making material changes to help combat climate change. In recent years, most of us have made environmental changes at home, segregating our waste or composting, insulating our homes or changing the way that we travel, perhaps even advocating for a political change of direction. But we now recognise that it's actually our work environment that could be the main source of our own personal carbon footprint. Back in 2017, a number of anaesthetists in Scotland became aware of an issue with our anaesthetic gases, and in particular DES, fluorine and nitrous oxide, mainly thanks to a talk by a man called Tom Pearce, who I like to refer to as the David Attenborough of climate science and healthcare. Over the next few years, grassroots action by working clinicians actually made a very effective change, a significant reduction in the greenhouse gas emissions from Scottish hospitals. And the good work was spread and repeated through a newly formed clinical network called Green Anaesthesia Scotland. And that work acted as a spark to ignite a lot of interest in other environmental actions in other areas of healthcare, because we now recognise that healthcare emits anything from 4 to 8%, depending which country you live in and what's the type of system. So 4 to 8% of a country's carbon footprint due to healthcare. And our duty now is to reduce that percentage and limit the damage. And of course, the actions we take are many and varied. But we have been, to be fair, working in the dark for some time now, mainly due to a lack of data and knowledge about the carbon costs of equipment, drugs and processes that we do in our everyday. And I refer to this as the black hole of procurement. So one of the key asks of our programme is to work better with national procurement to better utilise what's a massive purchasing power of Scotland's procurement budget, to demand full disclosure from our suppliers. So a complete lifetime assessment for all products and pharmaceuticals is something that we, I hope, feel should be mandatory, as is done already in many European countries. So to get started, what knowledge do we already have and what additional knowledge do we need to design the ideal green theatre from scratch? We should be looking at everything we do and everything we use and say, be asking the question, can we do that better from a planetary health point of view? I think if we think of an empty shipping container, what do we actually need to use to make that container suitable for providing safe and effective surgery? We probably need energy, but could we source it from renewable sources? We may not need anaesthetic gas scavenging. We may not need surgical 7-bar air supply. Do we need just-in-time supply of single-use plastics and metal items, or should we start cleaning our tools and using them again? Maybe what we need actually is 2 containers, one alongside each other, one to wash and sterilise our instruments and our textiles and reuse them in a kind of back to the future type programme. Do we need a car park outside, or would we be better with a bicycle park? And can we assess our patients online or by telephone as a default? We do need to even look at things like water supply in theatres. We may not need that. So today is the launch of the National Green Theatre Programme. It is an iterative programme, and we currently have about 50 discrete actions, most of which I have to say are cash saving for your hospital. It was interesting to see the poll there as being finance being one of the biggest barriers. But we hope to see that the programme at the end of the day will be a cash saving measure. The actions focus on energy use, supplies and equipment, pharmaceuticals and clinical practices. And David will talk later about the bundles and the delivery and measurement processes. But the model we're developing is to provide a template with guidance and evidence for each of these actions and implemented in a stepwise manner in every hospital in Scotland. Followed, of course, by assistance locally if required for any difficulties with implementation. So I'm not going to go through each action, obviously, but I thought I'd take you on a quick tour of a typical Scottish theatre to give you a taste of the small differences you can make that together we can help directly decrease our carbon footprint. So this is Theatre 2 in Regmore Hospital. I've attached some coloured arrows and some dummy surgeons, no pun intended. Let's look at water, the red arrow. 22 litres of hot water are used for every surgical scrub, and each operation probably has 4 to 6 people scrubbing. As an alternative, we could use rubbing with alcohol gel. It is as effective for antimicrobial protection and for surgical sterility as scrubbing. So perhaps we don't need scrub sinks at all. The blue arrow refers to correct waste segregation. This is not only a legal requirement and a cash-saving exercise, but it is one of the best recruiting sergeants in theatres for environmental actions. Most people hate waste and want to do something about it. The purple arrow refers to some pilot work already being done to quantify the benefits of reusable textiles, both gowns and drapes, and the steps we need to regenerate NHS laundry services. And the green arrow indicates a proposed innovation project we're working with now, looking at real-time monitoring of instruments and their use, and that will help with leaning surgical trays, reducing unnecessary opening of supplementals, and of course unnecessary sterilisation of unused instruments. On the next slide, there are 3 green arrows. These are about energy use primarily. These things are about things we leave on 24 hours a day, 7 days a week, every week of the year. So theatre ventilation and anaesthetic gas scavenging pumps are generally left running every day in Scottish theatres, and we need an automated, motion-activated system to reduce energy use by up to 66%. 7-bar surgical air, that's something that's provided 24/7 again, but despite that, it's only used for 4 minutes a day in orthopaedic theatres, and some theatres not at all. So local cylinder provision of 7-bar air could provide the necessary use and allow switching off of these industrial compressors. The yellow arrow, it's to remind us that even with the discontinuation of desflurane in Scotland, we do need to continue with good husbandry of the remaining volatile agents, with minimal fresh gas flows and end target control to minimise their contribution to global warming. And to finish the tour, the yellow arrow represents a few things for the future, and Phil's going to speak about our innovation arm next. But we have a study in progress looking at whether anaesthetic gas scavenging systems are actually necessary, given modern theatre ventilation capabilities. We're actively engaged in assessing volatile capture technology, possibly for destruction, but possibly even for reuse. But first of all, we need to assess the different methods and the providers in order to assess the capture efficiency. Nitrous oxide is a gas now used in only minimal quantities in anaesthetics due to clinical practice change, but it's still a major healthcare polluter from other areas in the hospital. So apart from dealing with the waste of nitrous oxide, we need to look at realistic alternative treatments, both pharmacological and non-pharmacological, in order to minimise the use of this gas, which remember has a 114-year atmospheric lifetime. Once we've done those steps, we can also look at the assessment of the destruction of the molecule. And of course, speaking of practices, Anaesthetic rooms are peculiar to the United Kingdom. We all know and acknowledge that anaesthetising patients in theatre has benefits for patient safety, for moving and handling, and there's a cost benefit to stopping duplication of equipment and space. We also know that the most wasteful time for anaesthetic volatile gas emissions is at the start of an anaesthetic. So we do need to question why we continue to prime and use 2 anaesthetic circuits and of course duplicate all our anaesthetic equipment. So across healthcare, there are so many different hotspots that can be tackled. And you might think you have no influence, but please remember that 80% of the carbon footprint of hospitals is due to clinical decisions. Surgical theatres are the most energy and carbon intense part of the hospital, and they're also responsible for a huge amount of plastics and pharmaceutical waste. So apart from the importance of implementing this programme in this particular hotspot, it's also the first step in a process which I hope will embed environmental sustainability in all clinical decisions and in all management decisions. Our job here with the NGTP is to help structure and support these individual actions into a deliverable programme. But we started with a blank sheet of paper and we've just begun to fill. So your contribution is essential. We will be working with teams across NHS Scotland, from the National Treatment Centre build teams to the engineers in NHS Assure and the infection control and decontamination teams. If you have any ideas or work in progress that would help deliver the goal of decarbonising our health service, then we want to hear from you and we want to offer our support. Grassroots, generally speaking, is where these things start, but it is essential also to have Scottish Government support and to have that work recognised in the climate emergency strategy. So we'd like to thank the Scottish Government, but more importantly, we'd like to thank you all again for attending today, and we hope you can help us deliver on this ambitious programme. Thank you. And I'm going to hand over now to Phil Corsa, the Associate Director of the Centre for Sustainable Delivery.
So good afternoon, everybody. My name is Philip Corsa. I'm one of the National Associate Clinical Directors in CFSD, but also an anaesthetist intensivist myself. Although my role is more about the organisation and organising the programme as opposed to necessarily anaesthesia. Ken has got that covered. But it was quite important for us to take the work that was presented to us as a commission to CFSD to try to turn what was a very effective grassroots team developing environmentally safe and sensible projects to go forward and turn that into something that was national, but still retained the grassroots work. It was very much about shared best practice, financial efficiency, health outcomes, and reduction in the contribution of our NHS to that carbon footprint. We felt theatres, like David said at the beginning, was a clear programme of work that was easily looked at and defined, but we're also very aware that actually the people who work in theatre also work across the hospital and across the rest of the NHS. So we know that this work should cross over into other areas. And like David said, as the CFSD, we're also very keen to ensure that the environmental work features in our projects and pathways going forward. But coming back to National Green Theatres, we were presented with quite a few actions, and we were up to about 50 actions, ranging from like Ken said, from the relatively simple into some of the actually quite complex. And I think having a program around us to help us work through that, like I say, provide evidence and provide clarity to anyone who was inquiring was important. So we divided some of the actions into structures in terms of, it was about the structures that we're working with, equipment we're working with, and indeed some of the practices we're practicing within the theatre suite. We also talked to some of the areas that were in the process of building new facilities like natural treatment centres, and we met with them to talk about what environmental sustainable action might be within their service. We're also very aware that there are several areas currently refurbishing, and we would want to engage in how we might help with that. There are in the future going to be some new buildings, and again, while they are required to have a net zero target, I think some of what we bring is the practicality of how we work for the people who will work in that building. In terms of opportunities, we've talked about the carbon footprint and how largely we've seen these to be cost neutral and cash releasing sometimes. But we also want to be very aware of that green dividend to allow us to take on things that are going to cost us a little bit to get started, but will give us the green benefits that we want to pull out of it. So this is something that allows us to measure what goes in, what we save, and potentially what we can invest in the future. But at the bottom of all of that is patient care. Clinical leadership with the special delivery group, and I'll just talk about that, but also harnessing innovation and building the evidence. A picture there shows you what we used to do. This is the beginning in the 1840s, 1850s. We've come a long way, but we've also used a lot more anesthetic since then. So we need to do something in what we do to improve that. So what is a specialty delivery group for the National Green Theatre Programme? It is a group of clinicians initially, with the bedrock being the green anesthesia group. But we've also now got surgeons in there. We've got infection prevention and control, estates, circular economy team, which is very important in making sure that we understand how to recycle. Our estates and facilities teams, national procurement are in there, alongside our theatre managers and the theatre nurses as well. Now, this is not in any particular order or in any rank. This is a group that meets and talks and understands and questions each other about what happens on the ground with a view to taking it back there. We would certainly there'd also be the advocates for those who don't work in theatre but have to manage theatres to understand what really this work is about. And I think that is quite key. And lastly, I would say a lot of the projects are actually written by the members, by the clinicians. The youngest contributor to our development of this program was a third-year medical student. And I think that was quite insightful for us to learn that our medical students are already very, very engaged. In terms of medical physics, I see there's a mention there. We are on the ground floor and the grassroots are always talking to medical physics. So, but if we need them in the SDG, I'm absolutely certain that we can arrange that. This is inclusive, not exclusive. In terms of our initial actions, you'll be aware of the desflurane, but we're beginning to make inroads into the decommissioning of nitrous oxide manifolds where they are not necessarily being required, sometimes replacing them with cylinders. But some of the energy saving actions like switching off ventilation and anesthetic gas scavenging systems and managing lights, etc., are genuinely potentially cost savings, but actually do not cause any harm to the anesthetic and the theatre environment. The fluid suction system is one that is worth looking at. There are some health and safety benefits as well as moving and handling benefits. But at the end of it all, we are still measuring our sustainability, environmental sustainability benefits from that. And lastly, we've talked about segregation there. We will send the slide around. This is, so I put this slide in not because I necessarily wanted to read it, but you saw Kenneth's slides at the beginning. The very last slide, which showed all the different actions which were not yet organized into pathways and ways of actually trying to get some science in terms of quality improvement science around it. And what the CFSD specialty delivery groups and the National Green Theatre Programme, as it is now, is set up to do is to take each of those and work them through with information and data to make sure that anyone who wants to understand them can do that. So lastly, around innovation and research, we are very aware that there is a lot that we don't know and a lot that we can't fix because we actually don't have enough information. And the one that took us to this organization, which is Medical Devices Manufacturing Center, which is a research and an area that works with business, but supported by the three big universities, Glasgow, Heriot-Watt, and Robert Gordon, amongst others. They're not the only ones, but also have some Scottish Government and some European support to help manufacturers produce the right pieces of equipment for not just health, but across the enterprise area. We've approached them from a healthcare point of view and engaged with them on some of the things that we think they could help us with, which is really exciting. They've engaged with us. They're looking at things like catalytic cracking of nitrous oxide, amongst other things. And some of the things that we've talked about with them and don't have answers yet necessarily, but are working on are things like the repurposing and the remanufacturing of plastics and metals, the reusable theatre drapes and gowns, replacing the plastic-based ones that we use just now, and making them theatre staff friendly. We've talked about some of the theatre trade and how we could effectively label them to make sure that they're easily traced and tracked around rather than all the cost of purchasing equipment that we don't necessarily need, or indeed the cleanliness of them. And we're looking at ways of cleaning some of our instruments on site using environmentally friendly processes. We've considered what sterile water we use, for example, which currently is bottled elsewhere, either in other parts of the country or indeed from Europe, and transported into our theatres. And we've looked at what we actually waste from our laundries, whether it be microplastics or pharmaceuticals. So there's a lot of work going on around what next. And I'm hopeful that we can begin to work through those in the near future. Thank you very much.
Thank you, Ken and Phil. It's really great and illuminating talks. I think it shows the breadth of the programme and the need that we can't do this as individuals. We have to do it together. I'm now going to introduce Alethea Chakira, who is the Head of Pharmaceutical and Sustainability, Health Infrastructure and PPE Division of the Scottish Government. And Alethea is going to talk us through medical gases and issues that we have with them. Thank you, Alethea.
Great. Specs on. Hi, everyone. Nice to be here today, and I'm really glad there's a great turnout. This is definitely a piece of work worth embedding in your places of work, and we're here to support you. So I'm just going to crack on. I'm just going to talk about anesthetic gases. I have an interest in a number of things, but obviously anesthetic gases is what we call a climate hotspot. Can everyone see the slides? Okay, just because I'm getting a funny view. I'm assuming everyone can see the full slides. Yeah, that's great.
Yes.
So I've stolen this slide from NHS England, but it really gives you a good idea of the magnitude of the healthcare footprint. A ton of carbon is equivalent to a flight from Frankfurt to New York, just to give a sense of our emission footprint. within the UK and globe and our healthcare, we're looking at around anaesthetic gases forming around 2%, but really in Scotland it's a bit higher because we've done so well with energy on the estates. The tide goes out and obviously that footprint seems larger. So it's a really, really important thing that we tackle. Just to give some context of these gases, because I know not everyone here is an anaesthetist and not everyone here works on green theatres. So you're dealing with desflurane, which the anaesthetists have really driven down. So it's 2,500 times more potent than carbon dioxide as a greenhouse gas. Something like nitrous oxide is 300 times more potent. Okay, so these are really poisonous greenhouse gases, and they form a film or a blanket over our planet, and this is what we call an emergency hotspot. So we really want to get them down, and there's a real commitment at a national level from the Royal College of Anaesthetists, the Association of Anaesthetists, and global interests from anaesthetists to get that down. So when I first turned up to Lothians around 2019, I really wanted to make a difference in sustainability. So I spent my time trying to understand, and it hadn't been done for Lothian, but I started reporting against the finance reports and also putting carbon metrics in, which was new. And this is my first attempt to try and understand the carbon footprint of Lothian. Now, this is really important because the Green Theatre programme, which draws a lot on Highlands work, is really about quality improvement and trying to understand what we're doing at a local level. And then good projects will then sort of feed into the national programme. But this was telling. But what I've also learned that this footprint resembles the rest of Scotland at the time. So that breakdown of 23% in 2018 of volatiles to nitrous oxide products is pretty standard for all of Scotland. So it's a pretty standard if you like, ratio for that period. It's obviously changed now with desflurane reductions. Okay, moving along. So our this is a little picture of Ken Barker. I'm only kidding, but he's kindly lent me this slide. It's there's our anaesthetists sinners, and I really don't believe so. I think they've demonstrated sort of very sort of what I call strong climate literacy. But we do know that the anaesthetic gases, their contribution because of their practice is hugely polluting. So kind of they're 100 times more, well, actually more than that, 1,000 times more polluting than the ordinary Joe on the street. So this was Ken around 2016. Delivering 8 hours of anaesthetic gas. We're looking at around over 4,500 kilometers in a car. That's quite potent, and when we can see that. And then, a handful of years later, he's done at 20 kilometers. And this is typical of most of a lot of the anaesthetic colleagues I work with. And this was also telling me a story that there was real agency, a real sense of ownership and respect for the planet and the way they conducted their practice. So all of this will feed into the next section. And then this is a combination. So you saw a graph with the desflurane earlier, but this is really a combination of all those gases. So that the emission footprint really was driven down by the anaesthetists giving up desflurane in their practice and crafting the way they deliver an anaesthetic accordingly. Also low flows but just generally really good advocacy. This has also led to savings with over if you're looking from, it's well over £1 million being sort of iteratively saved every year, because desflurane, you need 3 times the amount of desflurane than sevoflurane to deliver an anaesthetic. So just to give some context there. So I've learned a lot working with these guys. So what was next? So this is a fact. This is all about fact and fiction. This is about driving change. And to do that, we have to follow the evidence. And the simple fact is that anaesthetists have delivered more emission reductions than anything else, just by making choices, clinical choices, which is what Ken mentioned earlier. So through choice, they've managed to drive their footprint down. So from around 2017, they've gone from 10,000, just roughly 10,100 tons, and they've dropped to, just from the last financial year, to around 1,300 tons. I think a stretch target and reasonable target, if they continue to strip out the desflurane and continue to focus on low flows, not all we haven't got that fully across Scotland yet. We could stretch to 800 tons, dropped as far as that, and that's quite remarkable for a 5.5 million population, and I think that's possible. So what that tells us is that volatile capture can't achieve what the anaesthetists could achieve. So they've done far more through agency than anything else. So, so I won't go on too much about that, but we are looking at innovation in this area, but we have to be mindful that the innovation has to fit on that new tonnage reduction and not the other way around. Okay. So yeah, I won't spend too much on that, but we are doing studies on that, and we need to sort of stay mindful of that. And I'm talking to countries all over the world, New Zealand, Canada, at volatile capture. So there's a lot to be done on that, but the anaesthetists have really done all the hard work. So let's carry on. So knowing that and seeing that, my research was on nitrous oxide mitigation. I realized that my anaesthetists were really committed to, tightening up their anaesthetic footprint. So that told me a story, and I was just then, well, why is the nitrous oxide or anaesthetic nitrous oxide not coming down? And that was important. So, and why do I care so much about N2O? Well, it is a really potent greenhouse gas, so nearly 300 times more potent than carbon dioxide, but it's what we call an intergenerational pollutant. So it lasts up to 200 years in the atmosphere. So a child born today will be long gone, and the effects of the climate effects of N2O will still be felt. I won't spend too much time on this, but across the UK, it is really the dominant emission footprint at the moment, combining both analgesic and anaesthetic nitrous oxide. Today, we're focused on anaesthetic nitrous oxide. Why is it such a problem? Well, it's delivered differently from other drugs. It's delivered via a pipe system, and most of it's delivered, the anaesthetic nitrous is delivered through a pipe system, and that makes it sort of harder to track because there's many stakeholders involved in that. And I won't spend too much time on that, but we've got ways to deal with that. And one of the things is we recommend getting rid of your manifold. It'll make things a lot more cleaner and easier to manage. So one of the things we've done, and I think we've shared this out, is we've worked on improving data quality, improving data interpretation, help sites understand their system pathways, and so this, and anyway, all of this led to it. So this is the lean systems we're using to sort of really help sites understand how much they're actually clinically using and how much they're wasting, but really we're almost matured past that because we know that they're wasting so much. So very early on, we proved waste was between 83 to 100% from these systems. That was back in 2020. Within a few months, I managed to prove waste was as high as 95% on anaesthetic nitrous oxide. So it really was the message that we were delivering on the analysis was that these systems are really, really cumbersome. And what was driving it? System loss. So it's just these cumbersome systems are really hard to manage, and it's really hard for estate teams to go into theatres and say, is your outlet leaking? Because, they're busy places. You can't really do that. So this shifted the paradigm. We know that clinical utility was really actually quite low. Dentists, obstetric GAs, pediatrics, and actually system loss was the main thing. So just an interesting shift, in a very short period of time. So I've only got a few more minutes left. So, we're all about driving the loss down, and we're about optimizing clinical practice, but even that's less of a problem. And sure enough, we will look at alternatives, and we're also about assessing green technologies. So one of the things that I'm really keen on doing is continuing to work with the engineers and work with them to develop a strong implementation program. Both the clinical engineers and estate engineers, really, really important. And the other thing is that we want to keep continuing this because this is an iterative process. So we've built a lot of communication tools, but these tools will constantly be updated. And I think David mentioned earlier that we'll be delivering some how-to guides. So again, a more simplified measure on how to eliminate nitrous oxide or really drive it down will be released fairly soon. I'm conscious of time. So what's happened so far? Well, we've noticed that last financial year, we've just shy of 3,000 tonnes in pipe nitrous oxide has left, as it been removed from NHS Scotland. We're also working with partners across the world, and obviously nearest neighbour being NHS England. They've reduced their piped emissions by 18,000 tonnes because I work closely with a lot of their sites. So far, we've had 11 pipe systems decommissioned. I'm expecting another 16 to be done before Q2 of this coming financial year. And we're also focusing, next stage after all of this is Entonox systems. So I won't spend too much time on this slide. I'm just conscious of time, but we are looking at innovation in this area. But system loss is the priority, because once we strip out that loss, that will tell us how we need to supply this agent. Okay. Once we know how to supply this agent, that determines the right technology. Current technologies offered in Scandinavia are not appropriate, 100% appropriate for the UK system. So we're stimulating innovation. And one of the teams, I think Philip mentioned it earlier, was the MDMC. Brilliant guys looking at sort of low heat catalysis that would deal with all the nitrous oxide that's in it within a clinical area. It's really, really important. So I'm not going to spend too much time. These are some resources, but also do invest in the planet. You can't count your money if you can't breathe, you know. So I'll leave it there, but there's a lot more to talk about clearly. So thank you for your time.
Alethea, thank you so much for that Whistlewind tour. I mean, I think, you know, from the information that we've seen, if we get it right, there's about 30,000 tons of carbon that we can remove from our emissions, or carbon equivalents. And I think it's really important when we're talking about the manifolds that we don't just send the tanks back and vent them into the atmosphere, because that's what we're doing, but incredible amount of wastage as well that's not actually getting to a patient. So I thank you very much for your presentation. And moving forward, I'm just going to sort of finish off now with a little bit of highlighting sort of measurement and delivery and how people can get involved. I think, as we've seen, that the programme is working through, you know, 50+ actions that we are looking to implement across Scotland, and hopefully from today we'll generate some new ideas and take ideas and best practice that we hope people will share with us. But as part of the process that we're looking at, we're looking to identify what carbon emission savings are going to be in terms of CO2 equivalents and tons, and also what potential reduction in costs are going to be. And we're calling the costs green dividend. I've seen some of the questions in the chat about funding. The programme doesn't have lots of money to fund, but we will help people find out where grants are. But I think there is also a case for the programme to make a case for change. And I think if we can show the green dividend, which is looking not just at individuals, but the whole project and what the benefits are. Some will cost money, but we believe most of them will reduce the costs to the NHS. Obviously, at this point, we're in the 28th of March, we're having our launch event. We have worked our way through the first 7 actions that Philip highlighted earlier. I mean, some of those are almost complete, like desflurane, but we are going to be producing how-to guides on a regular basis, and those first 7 should be issued and released by the end of April of this year. I mean, it's our intention to when we produce the how-to guides, they will have individual health board opportunities for carbon savings and cost savings as a green dividend. We are using pilots, we're using evidence-based to calculate some of these. So part of the work that we will do with health boards is to allow them to validate those opportunities. So, for instance, if we talk about the surgical suction systems, I know a number of health boards have already been early adopters of that technology. So they will probably validate and reduce those targets. So we're not going to be, we want to make sure that the targets we put out are challenging and are realistic. But we also want to have that conversation with the health boards to make sure that those targets are achievable. And we then want to measure how they are delivered. I mean, I think this is real life targets. We've not done any of the validation yet, but we think we've got over about 35,000 tons of CO2 emissions there. But also we have saved on an annual basis about £1.2 million. And that's, as we say in green dividends, some are large savings, some are small savings, but we're tying them all together to show that the positive impact that we can have in both the finance and the emissions within the NHS. Now, part of today's programme is letting you know, the launch event is letting you know about the programme. we have a website that we will be developing over the coming months, where we plan to publish our how-to guides. We'll have lists of actions available, and also we will provide sort of program updates there. There's a QR code. You can take a screenshot of your screen. It will take us to our part of the Centre for Sustainable Delivery website. But I think more importantly, we have included the email address there. So if people have ideas, they want to be involved in the SDGs, we really are keen to get as much involvement as possible. We also want to support a number of health boards have already set up green theatre groups. I was at one in Ayrshire and Arran where they've actually got a whiteboard with the first 7 initiatives plus some of their own up within theatres. And I think it's important that we all buy into this process going forward. We are going to issue a short survey after this. We would welcome your feedback and comments on this. And I think that sort of concludes the sort of formal part of the presentation. We're going to move on to some questions and answers. If you do have any other questions, please continue to put them into the chat. We'll try and cover as many as possible. And where we may not be directly related to the programme, we will take those to people that maybe need to know about them. I think I'll be joined by Ken, Phil, Alethea, Caroline and Jason have had to leave. They've obviously got other pressures on today. And in addition, I'd like to welcome Ruth Innes, who is the Sustainability Manager for NHS Assure, but also probably Ken's partner in crime as part of the Green Theatre project going forward. So I am going to try and answer some of the questions, but I suppose that one of my first thoughts, and I've seen sort of the change, is why don't we just legislate for this? I think I would agree that we should legislate for some of this, but I would imagine that others may have any comments. So if you just want to pipe in, guys, when we're asking the questions, I'll go and look at the other questions.
Well, I think it's reasonable to have legislative around emission targets. I think some of the stuff is iterative and it's learning. So if you put legislation in place, it doesn't necessarily, like overly prescriptive legislation, it doesn't allow you agility to sort of maybe get to the best solution, because unfortunately with the Green Theatre programme, we are learning on the trot. So, if you go back even, me and Ken talk about this even 24, when I first started, people refused to believe me that we didn't need nitrous oxide manifolds, it started there, and it wasn't that long ago, was it, Ken? It was like, I remember the conversation, we first spoke in September 2020, and it was startling, and then, but by March, I had quite a lot of data lined up. So I think a lot of it's, what we don't want to do is if we legislate, we might miss a better trick, but I think you can have top line legislation, meaning you can have, broad figures, but micro detail is dangerous, I think, sometimes, but that's me. Ruth's nodding. She knows more about this stuff than I do.
Ruth, NHS. Oh, sorry. Yeah. Ken, on you come in.
No, Ruth first. On you go, Ruth.
I was just going to say off the back of that, Alethea, I think it's maybe not so much putting a legislation in, but it's sometimes challenging what's already in there. I can only speak really for around waste management, and we have had issues previously with some of the legislation that we are aligned to in NHS Scotland and Scotland as a whole. So yeah, I completely understand that question, but I think it's really a push on challenging some of what we are being asked to follow just now, which maybe doesn't make complete sense in terms of the green agenda, wider green agenda.
And I think I was going to say there's an opportunity for all of us here to speak to our political representatives, our elected representatives, both locally in councils and nationally, to tell them what we're doing, to tell them what we'd like to see, that kind of thing, because in fact, even local policies on things like active travel and provision of cycling paths, or there was some chat in the chat there about problems with electricity generation and feeding into the grid, etc. So these things can be highlighted. And I must admit, I've had a few conversations over the years recently with politicians, and generally speaking, they're very receptive. I've never come across a politician who thinks all this stuff is a bad idea. So feel free to make contact and start the conversation.
Thanks, Ken. I noticed someone had, oh, Philip, on you come in. I was just going to say quickly before Philip comes in, I noticed someone had put their hand up. I don't think the number of people, we don't have the facility to take individual questions being asked, but if you put it into the chat, we'll try and cover it. Phil.
Thanks. Yeah. So I don't know about legislation. I would worry about that. Like Alicia says, it can be a little bit imprecise. I'm actually probably more enthused by the ground up approach that we've taken and some of the benefits that we've seen. I think there's a worry looking at some of the chat there that people might not be aware of what's being put out there. And I think it is quite important that we reach. So if someone like Marianne, for example, who says, well, maybe we need some more local information, we are happy to go to health boards and run engagement sessions and have discussions with teams wherever in the hierarchy they sit, just to make sure that they understand what it is we're trying to do and how we can help them. Because I think actually this is very positive for everybody. We've tried to engage, and David and I were at the meeting with the executive leads for sustainability. So, you know, they like Ken says, they want to do this. So I think that's important to do.
Just to come in on that, not everything is legislation, but a lot of it is what they call best practice. So, for example, it used to be that it would be fait accompli that you would have pipe nitrous oxide in a building, right? So now we've got it in the SHTM as an amendment that it's not standard practice to introduce pipe nitrous oxide. Likewise, our authorizing engineers, who are excellent, by the way, we have excellent engineers in this country, are encouraging sites to really look at lean systems and work towards decommissioning. So it's really up to sites now, clinicians, and to settle on their lean systems. Every site's different. Some people will bracket a cylinder to the wall. Some will choose a cylinder at the back of the machine. Some will choose a cylinder and trolley. Layouts are different, and it's really important that you're settled on that and you're comfortable with it. But really, I think the engineers who are like, oh my goodness, that's not what we do, have warmed to the idea and are realizing, Leafy, the waste is, they're coming back and saying the waste is just too high. It's just, and it's unserviceable. You just need one outlet leaking one litre a minute, or a set of micro leaks, and that's 516,000 litres a year. And that's what we're dealing with. So I think we've changed the guidance. So sometimes it's just changing the guidance. And again, looking at it iteratively, like Ken was mentioning earlier, the AGSS outlets, we know now as we strip out the nitrous oxide, and we've also moved to high ventilation, high air, that the AGSS may be invalid. So all of these things are, a soft iterative process allows us to move and adjust our game with new evidence. So I think that's really, really important.
Thank you, Olivia. I think we've got a question which is round about the specific ideas that, you know, I think Ken and Phil were mentioning, you know, hot water versus gel, and asking if these are available anywhere that people can share. I think one of the things about the programme is we will be sharing that information when we do the initial assessment so that people can adopt it early, but we will still work through the full process. I don't know what your views on waiting for us to launch, or should we be providing that information early as well, both Ken and Phil and Ruth?
We certainly have a lot of evidence for the rubbing, not scrubbing, and it's available to the members of the SDG and the board and so forth. And as the bundles are released, in a stepwise manner. Hopefully that stuff will be coming out. I am hopeful that, in fact, if people are particularly interested, they will be able to access some of this data and research even before the release of bundles, so that they can get prepared and maybe make the case within their own organisation. But certainly once the website's fully stocked up with information, you should be able to find a lot of data on these sort of changes.
That's fine. I suppose we have another question. Oh, Phil,
Could I answer something that's in the question? So, just to top of what Ken's saying, you all have a representative within your own board, and maybe we should tell you who that representative is, because if you can't find that information, they definitely will be able to, and if they can't, they'll definitely be able to make contact with us, because we see them on a regular basis. I did put my hand up though to just respond to one of the queries about patient care. The program isn't aimed at changing practice or necessarily asking you not to do something which is good for patients. And I think we need to reassure patients, and I know Lindsay's replied in there, but this is about best practice as described by the people who participate in that. This is why you have to have the clinical groups there alongside everybody else. In regards to Propofol, no, it's not banished. But interestingly, we did have a conversation with the AVPI at one of their meetings about 1% versus 2% Propofol, and do we actually need both of them? And it's just getting an understanding of what we actually do. Nothing at this stage about doing anything with it. It's just being a bit sensible about how we practice it. Thanks.
Okay, so we have a question that's a little bit long. So someone is remembering when we used to use reusable drapes and gowns and reusable instruments, and the evidence was that we should then move to disposable ones to use. I think it was probably in relation to CGD and isolating used instruments. Have we turned round on our head, or has evidence changed, or why are we maybe looking at doing some of that? Ruth?
Yeah, I think there's probably a fair bit of work to do yet on that, David. You know, there is work ongoing just now in Highland on aprons, and, you know, a wider view taken by them for their new build in Lochaber, which we're working with them from Assure on. There's also a real interest. I attended Linen Services Group. I think Mary-Anne is on this call, but there's a real interest from laundry managers and folk like that, and particularly on reusable gowns and drapes. So I would say it's in development, but certainly a keenness for that, and working alongside infection control staff as well. It's I think we need to remember that's a really wide and broad-reaching discussion on what we do there. But it's a change of mindset, I think, is the biggest challenge, and Ken will maybe agree with me on that when we were trying to put this in Highland initially. So yeah, lots of work going on in the background, and we can share that, you know, as we progress through the bundles.
And I think that's the unique thing about the programme, Ruth, and the way that we want to develop the programme is about taking the work that everyone is doing and sharing that and as part of it. And the programme won't take the benefit, as you've seen. We've called out the, you know, NHS Highland as the sort of founding members of the programme, I would say. We have a question, which I think is probably an important question, Alethea, round about the decommissioning of nitrous oxide manifolds. And I think just now some health boards have a large number of bottles that they can't return, or we don't want them to return to BOC because it will just be vented into the atmosphere.
Yeah, so right. So the only reason people know about that is because of me. So that's been going on for years, and I'm not saying that's not great. So what we've been doing is working with BOC, which has been quite painful. I'm not going to lie, it's been painful. It's been going. It predates me. And what we've verbally, and now they've come back finally to say we just still, so don't get too excited, guys. This is painful. I'm not going to pretend to you. they're not taking responsibility for their their emission footprint at all. So what they're going to be doing is and there will be a call out, and it will probably come via your pharmacy procurement team. So they will receive the messages from NP eventually. But essentially, BOC in principle have agreed to take the 141G and 141J retirals from manifold closures, and then treat them. It'll be a separate pickup, and they will treat them differently. So they will devise a sustainable pathway for them. Now, I'm really keen for BOC to do this, because one of the other ideas we had was maybe coming up with a peripatetic solution that would come and crack the gas on site. However, I think I won't go into a long discussion about it, but I think we decided that no, we'll actually play the long game and work with BOC to develop a sustainable pathway, because we actually want them to start dealing with these gases when they come back in a sustainable manner, because there's nothing to stop them. There's nothing to, stop them. It's not a priority for them. So we've put the pressure back on BOC. And so yes, you are, but you should still terminate your manifolds. And I don't mean to be funny. You guys have been turning over millions of litres. You can hold on to your rentals a bit longer. So I know people say, oh, we're paying rent on it, but we've been sort of neglectful for about 4 decades, if not longer. So we can take the hit and pay a bit of rent. It's cheap, and get BOC to lift their game. So I'm hoping we've got a really great sustainable lead person called Abby, who's fantastic, and David, who's also ex-MP. We can get that on our contracts and have those retirals dealt with differently. But also it forces BOC to develop a sustainable route for these gases. That means any other cylinders we send back, be it Entonox, half full, or even the little residual gas you have at the end, has to be fully vented. It will eventually go through a sustainable route, and BOC will hopefully lift their game. So yeah, we've put the pressure back on BOC. So hold on to your cylinders. Don't get too anxious about them. Pay a little bit of rent. It's cheap. Don't worry about it. As long as you're not turning it over, you should be happy. You're doing your climate duty.
We are running out of time, but I think I'm just going to try and pick, I think, a question that I think is probably important. Which it's 2 questions. I'm going to put them together. Is how would we encourage anaesthetists to stop using anaesthetic rooms? This person gets the duplication of machines and the gases. And also, is TIVA now taboo? It's conspicuously not mentioned. I'll pass that to Ken and Phil.
I'll do the anaesthetic rooms. You do TIVA, Phil. Yeah, anaesthetic rooms is one of these difficult subjects. We like them. We like the space. We like the peace and quiet, etc. There's lots of arguments for retaining them in terms of theatre efficiency and privacy of the patient. Really, it's if you're going to look at adopting a non-anaesthetic room system, then you need to look at the whole system and utilise what's currently used for anaesthetic rooms, perhaps as a scrub preparation area where they can open trays and so forth. And you need to talk to your surgeons. You need to be able to call for a sterile cockpit, but at peace and quiet when the patient comes in, etc. So there are a few things to do, but I think it's something that's been a bit taboo. We don't want to address it because it's what we've always done. But I think there are good enough reasons now to look at that question again in the light of the health and safety, the patient handling, etc., patient safety and environmental reasons. So I've been a big supporter. I've worked with a non-anaesthetic room system in Sweden, and really, after a week, you don't even realise that the anaesthetic room isn't there. And in terms of theatre efficiency, I think most people that do work in that kind of system feel there's not a great difference, if at all. So that's a conversation I'd like to have further time on. Phil.
Yeah, no, Ken said it all. I'd agree with you. But I can understand why people want them, and not necessarily for anaesthetic gases. And if you had a room that did not have anaesthetic gases in for whatever reason, which could be cleared by many theatres, that'd probably be one way to go. But that might need hospital redesign. So the question was around propofol and TIVA. Total intravenous anesthesia is, I think, going further up. I was trying to find a data slide on the use of all the anesthetic gases. It was quite interesting to me that as desflurane dropped significantly, and you've seen the slides already, there wasn't a corresponding increase of sevoflurane as the only other anesthetic agent of that quality that we have, or indeed of isoflurane or any of the others. So there's a gap there somewhere, and I have no evidence that it's TIVA. It might be just pure regional anesthesia. We are supportive of it. Like I said, we are looking at everything, and if we're using a lot of 1% in theatre and 2% in ICU, that doesn't make sense for infusions. You could have a higher concentration and use a less in terms of syringes and disposable. So that's the pure practical thing. But from the actual practice of TIVA, there is no objection from my point of view or anybody else's. It is quite interesting, though, that we are looking at the pollutants in water. And I don't know whether it features yet, but it's something that we will look at as well.
Alethea, final comment?
No, I think there is ecotoxicity attached with propofol, and Ken and Phil can talk on that at length. I think what's interesting is some of the work that Ruth Innes has been led on earlier around pure water and around glass filtration capture. Because the glass is ionized and it can actually attract a lot of drug molecules out. So there's opportunities there. But one of the reasons that sevoflurane has gone up, but not excessively, and that's mainly because desflurane, you need 3 times as much des as you do sevo. So there's that as well. But I think one of the things, I have done some tracking on propofol, so I'll pull out a slide from many moons ago, and we'll get that data up for you next time, maybe. Oh, Ken's going to say something?
I think he was saying 4 times. So, Alethea...
no, it's not. It's 3 times. She's quite right. It's 4 times as expensive.
Yeah, it's 4 times as expensive. Yeah, it's really pricey. Pharmacists don't like it. It's too expensive. We're cheap.
Yeah. So we've lots of other questions. I think the plan is that we will take those questions. We appreciate people asking them, and we will provide responses. I think one of the questions was, can we fund exemplar theatres? At this point, we probably don't have that money, but part of what we want to look at is where there is a national approach to be taken. Can we write a business case that would allow us to access funding from the Scottish Government in terms of capital to make that, but we'd have to have national agreement on that. And the comms was another issue that people had in terms of how are we going to communicate. We will do it through our website, but if there's other groups that you want us to come and speak to, come and talk about the programme, we are happy to do that. We're happy to support local groups. So just get in touch with us. As I said, if you want to be a member of the SDG and come on this journey with us, please send us that email. We will share the slides after the meeting to allow people to access those details. I'll ask the team just to email everyone with the contact details if they don't already have it. And I'd just like to thank the presenters, Ruth, for coming in at the end. I hope to see you all in the future, and thank you very much for attending.